Hi, this is Dr. Len Calabrese. I'm a professor of medicine here at the Cleveland Clinic Lerner College of Medicine and the director of the R.J. Fazenmeyer Center for Clinical Immunology here at the Cleveland Clinic. I'll be discussing probability and impact of achieving low disease activity or remission in patients with psoriatic arthritis treated with Apremilast, pooled analysis of the PALLAS 1 through 3 phase 3 trials. This is presented by Dr. Ian McInnes and colleagues, and they recently presented this at EULAR 2018, just held in Amsterdam. I just got back. It was a fabulous meeting. I'm still kind of ciphering what I learned there, but there's a lot on psoriatic arthritis. So let me summarize this for you first. I think the study shows us the chances for achieving low disease activity or remission with Apremilast were greater for patients with psoriatic arthritis in the CDAPSA, that is a responder index that we are increasingly familiar with, in the moderate disease activity category, 13 to 27 at baseline, or week 16, compared to patients in the higher disease activity category. Also, achieving low disease activity or remission at week 52 with Apremilast was associated with good outcomes across core domains of psoriatic arthritis. So let's get into how we did this, because the importance of this is that this suggests that patients with psoriatic arthritis who have baseline moderate CDAPSA disease activity may be particularly suitable for Apremilast therapy. So let's dive into the methods a little bit. The PALLAS 1 through 3 studies, most of us are familiar. These are large, robust trials that formed the basis for the approval of Apremilast. This is a pooled analysis of patients treated with Apremilast, 30 milligrams twice daily. To be eligible, patients had to complete 52 weeks of this therapy and have components of the Clinical Disease Activity Index for psoriatic arthritis, so-called CDAPSA score, available. Results were grouped according to CDAPSA categories at week 52. You had low, moderate, or high disease activity. So in this study, the key element is classification according to the CDAPSA categories at week 52. And if you're like me, you don't remember these scores off the top of your head. Remission is 4 or less on this scale, whereas low disease activity is 4 to 13. Moderate disease activity is 13 to 27, and high disease activity is 27 greater. Key findings are, first of all, 374 patients were included. The means of the baseline CDAPSA scores were 41 or less, associated with achieving of moderate or low disease activity and remission at 52. So we'll come back to that number. Patients in the high disease activity group at baseline had a 42% chance of achieving moderate disease activity and a 24% chance of achieving low disease activity and a 5% chance of achieving remission, while patients in the moderate disease category had a 41% of achieving low disease activity and 12% of achieving remission. So you have to go back and look at the comparator limb. So this is 41% versus 24%, and 12% versus 5%, favoring those starting in the moderate disease category. Patients in the low disease activity group at baseline had a 20% chance of achieving remission. Similar trends were observed upon response at 16 weeks, so it gives you a little chronopharmacology here. For example, patients with moderate disease activity at week 16 had a 38% chance of achieving low disease activity and 2% chance of achieving remission at week 52. Achieving CDAPSA low disease activity or remission at week 52 was associated with residual disease activity. For example, you could have swollen joints of 1.2 versus 0.24, and these comparator groups versus tender joints of 2.6 versus 0.5, and dactylitis score of 0.47 versus low. So better to be in remission than to be in low disease activity. Removing patients with high disease activity at baseline suggests that CDAPS of 21 was associated with achieving low disease activity or remission at week 52, corresponding to a mean 5.5 swollen joint count and 9 tender joint counts at baseline. So I've given you a lot of numbers. What does this mean? Well, when I approach patients with psoriatic arthritis, and I'm trying to pick from this wealth of drugs that we have available to us, I divide patients into 4 plots. Bad joints, bad skin, bad joints, mild skin, bad skin, and mild joints, and mild skin and mild joints. And so we have this matrix. You know, we have TNF inhibitors, we have IL-17 inhibitors, we have drugs down the pike, we have conventional synthetic DMARDs. I like Apremilast in particularly for patients with more modest skin and more modest joint disease. You know, the drug is an oral drug. It requires very little therapeutic monitoring. If patients get through the initial phase of tolerability, it has a very low dropout rate. And here we provide data that perhaps people on the milder end of the spectrum are going to be the most robust responders. It's consistent with the way that I have practiced with this since the drug was introduced based on relatively limited data. So this is very reassuring to me. Now I might add, you know, this does not mean that patients with more severe forms of the disease don't respond, but if I had to pick the sweet spot, this is what it has done for me. So I think this added considerably to the literature on it, and I thought this was a very nice way to project the data. Thanks.